I'd like to welcome everyone to this session. This session is on how does radiation affect breast reconstruction? And my name is Joan Lipa. I'm a plastic surgeon at Sunnybrook Health Sciences Center in Toronto. And I have some of my esteemed colleagues that are here with me. They are also from Toronto. So just for introductions, we have John Semple, Dr. John Semple, who is at Women's College Hospital, waving there to you, and Dr. Stefan Hofer, who is at University Health Network, both professors in plastic surgery. Joining us a little bit later on, hopefully, will also be my colleague, Dr. Laura Snell, who is also a plastic surgeon specializing in breast reconstruction. So first of all, thank you everyone for joining this session, and I hope that you're going to find it informative. So just some housekeeping points first of all. So the audience, so the attendees are on listen only mode. So what that means is that we can't actually hear you, you can hear us. And what you need to do is you need to actually use the question and answer link that you should be able to find on your screen to post questions. And then I will try to ask those to our panelists. And if at any time you want to leave this session and go to one of the other sessions, then you can log out of this one, close this Zoom session, and then return to the event website where the links to the other sessions will be listed, including the show and tell lounge. So the basic topic here is that we want to discuss the effects of radiation on breast reconstruction and what options are available to you for women who either have had radiation or may need to undergo radiation in the future. So until we get some questions that are popping up in here, I thought we'd just sort of do some, introductory questions that maybe either Dr. Semple or Dr. Hofer could offer an answer to. So can you just explain, how does radiation affect the tissues? We know that it's being used to help to treat the cancer, but what does it do to the tissues that are also radiated?
Right. Anyone specific? I can start.
Sure.
So obviously radiation is not only the enemy of cancer cells, which is a good thing, because after the cancer cells have been removed by surgery, there always may be like a few individual single cells remaining that later on, months later or years or many years later, grow into a new cancer or go elsewhere in the body to grow cancer. So it's good to radiate to get cured and get rid of the cancer. On the other hand, because radiation kills cells that divide, like cancer cells, it also kills cells that divide that are kind of actually useful cells. Like our blood vessels that always kind of renew themselves and help us with wound healing. And the problem with radiation, therefore, is that the little blood vessels in the area where it's been radiated, they are actually being damaged for the rest of your life. It never heals fully again. And if you start a breast reconstruction, and I would say especially a breast reconstruction with implant material, the tissue with the damaged blood vessels from the radiation really doesn't respond very well to this foreign material and to the stretching that we want to do and to the implants that we want to put under that tissue. So that's a concern. So in my mind, and I think in most people's mind, it is very difficult, dangerous to just do a breast reconstruction with only implant tissue after someone has been radiated. And that's because of the permanent damage that has occurred due to the radiation.
So I just wanted to welcome Dr. Laura Snell as well. I'm just trying to figure out now if I need to unmute you. There we go. So welcome Dr. Snell as well to this panel. As I promised, she'd be joining us as well. So you've said that, that you never really want to use an implant only under radiated tissue. Are there ever any situations where that could perhaps still be considered? I know that a lot of women ask that. Maybe Dr. Semple, do you want to take that?
Sure. I think that from our reconstructive point of view, first of all, I think we all agree that if the team recommends radiation, that radiation is very important to consider as part of your treatment if it's recommended. And knowing that I was going to sit on this panel, I did phone one of my rad-onc colleagues and ask about any advantages or any sort of improvements in radiation in terms of the breast reconstruction with implants. And I think they feel that there have been some modifications on how they deliver radiation to the tissues. They try to spare as much of the tissue as possible. They do less boosting on the scars. They do, and they're even without prompting, they do see more favorable results with radiating on top of implants in terms of direct implant type of reconstructions. But to answer your question, the issue around whether once the tissue has been irradiated, we often can use fat grafting to minimize some of the damage in terms of reversing some of that. It doesn't reverse the cancer treatment aspect of it, but it does allow us to stretch the skin under certain circumstances. I think, so I would say that I just want to say also that all cases are quite different. Even though we talk in generalities, every patient has to be considered as an individual, and what may work for one person may not work for another.
Right. I think that that's a great point. Every woman is different. So we have a question from the audience that I think is a good one to work with. So there's a lady who's had a double mastectomy and radiation over 10 years ago. She had implants and she recently had to have her implants removed and now she's flat. Is it possible to do a breast reconstruction with fat grafting alone?
That would probably be a good one for Dr. Semple. But in my experience, fat grafting alone with a radiated mastectomy defect is quite difficult. Fat grafting can be used as an adjunct. So like Dr. Semple alluded to, sometimes we can use fat grafting into a radiated mastectomy defect to help soften and prepare the skin for expansion using a tissue expander, for example. But even at that, sometimes the tissue can be tight or difficult to expand with a tissue expander alone. So typically just fat grafting alone is not enough to do a full reconstruction. The ultimate sized fat graft is of course a DIEP flap or a tissue flap from your abdomen or from your medial thighs. And that's basically a whole bunch of fat, but it comes vascularized or with its own blood supply. And that can typically be a more reliable way of creating a larger breast reconstruction or a fuller breast reconstruction in a previously radiated area.
Thanks, Dr. Snell. So basically, it sounds like, it's very difficult to create an entire breast out of fat grafting alone. There is a thing called Brava that and has been popularized and has been used in some centers. Maybe can anyone comment on using sort of something to expand the tissues first and then use fat alone for a breast reconstruction?
I think Brava is no longer available though.
Exactly. So that's why I wanted to bring it up, because sometimes you'll still read about that and a lot of women will come in and ask me about it, but it's really not available on the market. And I think too, especially with very radiated tissues, it's very difficult to get that much volume with fat grafting alone. We tend to use it a lot more for either preparing sites or smoothing out contours.
Yeah, I think it's also important to realize people always think that fat grafting is maybe less invasive, but I've been part at conferences of life surgeries where this was done like in the next OR, And those are very, very extensive fat grafting procedures. And then that's the first stage. Often there's 2, 3, 4, or even more stages where you have to go under all the time, every time, to add more fat. So it's not like a simple operation that's like a minimal operation. It's actually a lot of work and a lot of anesthesias.
Okay. So there's another question. In Toronto, do we ever do reconstruction prior to a patient receiving radiation? And if so, what is our experience with the impact of radiation on the reconstructed breast? So, and I think we should sort of look at it maybe in terms of implants and in terms of tissue. Does somebody want to take that one?
So I think I can start. I think we all probably have lots to say about this topic, but every patient is different. So while there's big generalizations, which is if somebody is for sure going to have radiation, or we know radiation is part of the treatment plan, reconstruction should be deferred, that may be a big generalization. And there are certainly many situations where we don't follow that generalization for our patients. Many situations for particular patients where we would consider an immediate reconstruction that is either implant-based or tissue-based for that person, despite knowing that it's going to be radiated. And there's a lot of factors that we take into consideration in those situations, such as, the actual patient themselves. So what does your tissue look like? What is, is it, if you're going to have an implant, what is your skin going to look like? What is the size? What size are you hoping to have? What is the other breast going to look like? In addition to, if we're looking at a tissue-based reconstruction, how much tissue we're going to have to work with, et cetera. So there's things that we consider when we're trying to give that recommendation or our advice about that. And the other thing is also what your opinion is in terms of how you would like radiation and reconstruction to fit into your cancer treatment plan. So my comment, I guess, to start with for this topic would be, there are certainly situations where we do immediate reconstruction on patients that are going to be radiated.
Okay, and then can anybody comment on how either expanders or implants, or Stefan, you've got something to say?
Yeah, we tend to see every patient who has an interest in reconstruction, whether they need to be radiated or not. And every patient who will be radiated, unless there is an exceptional circumstance, can have breast reconstruction, like an immediate breast reconstruction. I think the way we do it nowadays is if someone really wants an immediate breast reconstruction, even though they need to be radiated, we start off with a tissue expander to preserve the skin. And there are a number of patients who want to go the tissue route, and then we will replace the tissue expander at a second stage with the own tissue, or patients who want an implant. And if the tissues look well enough after the radiation, after it's been a healing period after the radiation, we put in an implant. So it's not like maybe a couple of years ago where someone who needed radiation for sure, we would say, well, just come back afterwards. No, if someone wants reconstruction, I think everybody has the opportunity to get reconstruction currently with us.
I agree with Stefan. That's an excellent approach. We also at Women's College, we will do a direct implant before radiation, and we've had pretty good results with that. Whether we know they're getting radiation or not, sometimes it comes up after they review the pathology and the lymph nodes. But depending on the patient, the thickness of the flaps, we've had good results with that as well.
And we do know that radiation changes the reconstruction. So if we know about it ahead of time, we sometimes make accommodations in the way we reconstruct the patients and set the implant, for example, in a slightly different way, or the tissue reconstruction in a slightly different way, knowing that it may change a little bit with the radiation.
Okay. And some women have sent in questions beforehand. And one of the questions was, why are some people not given the option of reconstruction before radiation?
I guess that's hard to comment on because I guess we are very pro reconstruction, all of us. So I think in our centers, that's almost an automatic given that our breast surgeons know what we do and work with us. I think if there's less familiarity with breast surgeons or medical oncologists, maybe, that it's not offered, not because they don't want to, just because they're unfamiliar with it. I think that's the whole goal of our existence, is to bring breast reconstruction awareness and ensure that everybody at least gets a chance to think about it.
Yeah, I think that that's a good point. And so some of the other questions that have come in. So there is a patient or a lady who's had a single mastectomy followed by 5 weeks of radiation treatment. And she wants to know if she's correct in thinking that she wouldn't be able to get implants, but would the option of using her own tissue be available to her? So we've already answered a little bit of that, but maybe, we could emphasize some of the take-home points there.
So I think she sounds like she would probably be, you would have to, we would have to examine you, of course, but somebody who's had radiation and on a mastectomy defect is usually a very good candidate for reconstruction using your own tissue. Where the tissue comes from, it depends on what things look like during the clinical examination, but that's typically a perfect situation for an autologous or tissue-based reconstruction.
Okay. And then there are quite a few questions that are coming in various forms about the placement of implants. So sometimes implants are placed behind the muscle. Women are asking pretty much if they can be placed in front of the muscle, or if they can be potentially changed out from behind the muscle to in front of the muscle. Can somebody take that and maybe say, what are the potential limitations? When can that perhaps be done? And when perhaps can it not be done?
Which one is that, Joan, the switching out from?
Yeah, or even who could potentially have their implants placed above the muscle, and to avoid sort of the implants maybe moving or jumping sometimes, or to give a different appearance to avoid disrupting the muscle. And when would it possibly be recommended or a decision made in surgery to put them under the muscle instead, or partially under the muscle, which is, another way of doing it? So
with the more common approach of using what we call prepectoral, or putting the implants on top of the muscle, just under the skin, I think there are many advantages in doing it that way, particularly, unfortunately, because we often see younger women with breast cancer, and it avoids, almost anybody, all women. I think we try to avoid doing any extensive dissection or using the muscles if we don't have to. So I think we try to preserve the anatomy for everybody as much as we can. I think that, and it's interesting, there are more studies out there now that are looking at prepectoral implant placement with radiation. And a lot of those studies do show that in the groups of patients they've looked at, that there is comparable results with this, with the positioning under the muscle. But I think there's also provisos in there that patients that are heavier or have a larger BMI tend to have a better result overall with the prepectoral. As well, in Canada, we are more limited in terms of using a cellular dermal matrix, which a number of the studies in the US completely gift wrap the implant in prior to placement on top of the muscle. So I think that there's certainly progression and development. It's an area that is developing fairly quickly. So we're seeing more patients with that for sure. The idea of switching out from under the muscle to on top of the muscle, I think would be only in situations where somebody had a lot of muscle movement with with their activity that was encroaching on being a disability in terms of what they wanted to do. Or so I think that that's something that they would want to talk to their plastic surgeon about in terms of what options they have in that regard.
Okay. And what about the woman who's had a breast implant reconstruction, and then she's had radiation, and then she gets something called capsular contracture, so where there's a lot of scarring and firmness and hardness around the implant. So that's certainly something that can happen post-radiation with implant reconstructions. So this person wants to know, is that a lasting effect? Will it ever improve on its own? Can it get worse? And sort of what can be done about it?
It's a difficult problem, and it can be very uncomfortable for patients to have a tight capsular contracture, especially after radiation. Typically, though, once a capsular contracture has developed, it doesn't really get better on its own. It can stay how it is, or it can get a little bit worse, but it usually doesn't kind of peak in terms of how severe it is and then tend to improve significantly over time. So, you know, typically for my patients, if it gets to the point where it's bothersome on a daily basis and really causing a lot of symptoms and discomfort, it would be something that we would try to come up with a surgical plan for, such that and it would depend on the clinical examination and how the patient, how your tissue felt, like your skin and your fat and how mobile it was. But there's different options and different approaches to trying to address that, such as releasing the scar tissue or the capsule and changing to potentially a smaller implant, potentially using some ADM or an acellular dermal matrix. And then another option sometimes can be changing the implant for a autologous reconstruction or your own tissue if it's a severe capsular contracture.
Okay, thank you.
Yeah, I think it's important to say with all these things, if you start revisional surgeries and radiated skin with an implant underneath, you have to be aware that there's a much higher risk of complications, implant infections, implant loss. It is quite a risky surgery, so there should be a really good indication to do this. There should be real discomfort. It's not a simple thing.
It's a very good point. Yeah.
That was one of the other questions, is what are the risks of reoperating on the radiated skin? So correct, It's not straightforward, because again, those effects of the radiation keep on, you know, they just keep on giving. So let's talk a little bit about women who have had a lumpectomy and radiation. So first of all, can they eventually go on to have a total mastectomy and reconstruction after that? That was one question from the audience.
Yeah,
absolutely.
I think I'm very comfortable if the skin envelope, if the skin that someone has is intact and there's no skin missing from the lumpectomy, because sometimes a lot of skin is taken and the breast already looks deformed. But if the breast is normal looking and the skin hasn't suffered too much, then I would just treat it under caution that it's been radiated and there's a higher chance of complications. But I would just treat it as if it's normal skin. But if there's skin missing or if there's a lot of damage, then I think someone has to be prepared to have some of their own tissue added, either with some skin and muscle from the back or as a complete autologous own tissue reconstruction, rather than trying to stretch skin that won't stretch or have a really high risk of failure and disappointment.
Thank you. So that was another question that a person was asking, is if they've had radiation to the breast, does it affect the back or the latissimus area? Can they still have latissimus? And I think that you've answered that that's actually a really good option for women who have had radiation. So there's...
Yes, I guess just if there's just some skin needed, if the skin looks good, but there's just some skin needed, then I would add tissue from the back without the muscle. Like that's a different kind of flap. It's the latissimus dorsi muscle skin flap without the muscle, like a tap flap. So
Yeah.
then you can preserve the muscle in the back and just add some skin from the back to make it less of a big operation.
Perfect. Thank you. So I think this is a good one too. For women that have expanders or implants in place and are then going through radiation, are there any tips or tricks or things that they can do to minimize the impact of radiation? So either adjunctive things they can do during the radiation or, number of sessions, how does that impact? So again, we're not radiation oncologists, but if anybody has a tip or trick, I think that that's sort of more the issue about how many sessions, I think that should be brought up with the radiation oncologist. But any things that can be done for the skin, for instance, or to minimize those effects on the implant?
I think there's nothing is really proven there, as far as I know, other than good skincare.
Yeah, I think the good skincare, as Dr. Hoffer was pointing out, I think that the radiation technicians and radiation oncologists now will often suggest using moisturizers and cream like that, as far as I know, between sessions to treat the skin. And I think that the radiation oncology groups now are working very hard to minimize the dosages that they give that still maximize the treatment to the cancer, but preserve as much of the surrounding tissues as possible.
I also, I find, and this is again, not based on evidence, but just what I suggest in my own practice, is that once the radiation is finished, I do get the patients to kind of massage their tissue expander a little bit, try to move it around a bit, just envisioning myself creating a slightly bigger capsule. And the other thing that I find very difficult is re-expanding after radiation. So I tend not to do that. So when my patients are sent for radiation, they're fully expanded, because I find that the reconstruction doesn't do very well if the radiation is on a non-fully inflated tissue expander, and I try to expand afterwards.
And again, I'd just like to thank everybody and hope that we were able to answer some questions. Okay, goodbye, everybody.
Thanks, Dr. Lipa.
Thank you, Dr. Lipa.
Dr. Semple. Thank you, Dr. Hoffer. Thank you, Dr. Snell. Have a good evening.
Tomorrow.
Bye.